Yes, I think that
Record.
makes sense.
Here you go. Thank you,
All right,
Heiner.
got it. Got it. It's recording now. All right, so ladies and gentlemen, first of all, thank you for inviting me over. And a small introduction about myself. I am a medical doctor, a clinician with about 42, I think, years of experience now. I've also been working in the domain of healthcare informatics for approximately 20 to 23 years now. Um, I am a person who is passed out from the army medic. We have a college, the medical college, or a medical school, as you call it there, the Armed Forces Medical College, which is one of the well-known colleges. I passed out in 1980, and I joined the Air Force, the Indian Air Force after that. So I worked in the Indian Air Force and became the Deputy Director of Medical Services as a wing commander. And that is when I left and joined the Apollo Hospitals Group, worked for them for telemedicine. That was somewhere around 2000. So worked with them as the head for telemedicine. I was the vice president for telemedicine for them. We did a lot of implementations all over India and also in places like Kazakhstan and so on and so forth. I since I write code and I program in 5 languages, I'm the actual link between a doctor and an IT person to make software to help make software that works and doesn't kill patients. In short, well, while I was in the Air Force, I got interested in trying to do something for the poor people in villages because most of the time you're posted to very remote areas. And in these remote areas, those people who live there do not really have much support, much healthcare support. So we used to, go out, uh, once in a week or so, or once in a fortnight, and try and provide primary healthcare to them, medicines, investigations, and so on and so forth. And that's where I felt that there's a lot we can do. For example, in India, we have almost 600,000 villages, and we just have about 24,000 clinics, basic primary clinics from the government side. The government is trying hard, but then there is a lot more that we can do. And that's where I got this idea that why cannot I give people in the villages the same quality of primary healthcare? Because my focus is primary healthcare. If you can prevent illnesses and take care of it the moment it comes out, we can obviously ensure that a person lives a happy, healthy life and has a better quality of life. So that is where I said, okay, let's try and do something by which I will be able to take healthcare at least 6 days a week, if not 7 days a week, to the villages and to every village. Now that was a tough thing because it had to be very, very inexpensive. It had to be of the same quality of care. The medicines had to reach the patient. It has to be the same quality of maybe generic medicines, but the same quality nevertheless. It All the tests that you do in primary care should be done out there, and we must ensure that doctors are available to provide services. Now that is pretty difficult because, as you know, we have a shortage of doctors in villages. Per se, we don't have a shortage of doctors. That's a paradox. If you go to any of the cities, in fact, one of our cities called Mumbai, we have more doctors per square kilometer than even New York. But then that's a problem. You see, every doctor wants to stay in the city. Obviously, he wants to live a good quality of life. Human beings are the same, you see. So we have a very, very bad shortage of doctors and nursing staff in the villages. So I put together a plan in which I said, okay, I will create design, a new design of a vehicle, which would be a clinic, a mobile clinic. It would be an ambulance, and it would also be a telemedicine center. So that way, all three problems would be sorted on one shot. So I couldn't find something which was appropriate. So I designed one. And now we have applied for a patent for it. And they're in the process of granting us a patent. We're waiting for the paperwork. It takes time, In India, it takes 7 to 8 years to get a patent. Nevertheless, it's on. So this vehicle that I call the Ambu Pod is a very small three-wheeler, and it carries everything you need for primary care plus emergency care. Now, using this, we use a a design methodology by which a doctor sitting in a city can visit multiple villages, thereby improving the amount of care that you can give to more patients. In other words, this vehicle will go from village to village to village in the same day. There'll be a schedule in which it will go to each village. A doctor through telemedicine will see the patient. Meanwhile, the person who takes the vehicle would be trained, the telemedicine manager. He would take down all the clinical parameters and symptomology that is required of the patient, his clinical signs, his clinical symptoms, his complaints, and so on and so forth, and feed it into the application. We have a tablet and we have an Android application which is connected to the cloud. And it's also been made in such a way that it will work even if there is no connectivity. It will take the data and it will sync up data. So using this application, a patient in the village can every day go to his local clinic, which will come and park in a certain place. This Ambipot, he will then give his details to the medical person, rather I would say the locally trained. This is how we are increasing the number of locally trained people in basic healthcare. That person will take down his details. He will know how to take the blood pressure. He will know how to take his temperature, and so on and so forth. And then this data is passed to the doctor. Then the doctor connects up, talks to the patient or sees the patient and decides what treatment is to be given. He first does triage. Now, as you know, in French, triage is to sort out. He decides, can I see the patient through telemedicine or should I, refer him? Based on that, he would be able to treat at least about 70% of cases locally. Now, we go beyond telemedicine. We call it 360 degrees of care because not only does he see the patient, which telemedicine does, but he also prescribes an e-prescription and the medicines are given to the patient right there. If he asks for an ECG, it will be done right there in the village. If he asks for a blood sugar, it will be done right there in the village. So there is comprehensive care in the village every day, at least 6 days a week. And it is just like you have it in the cities. And the cost would be less than $1 per consultant.
Wow.
An ECG with a report for less than
Lavanian, I made you co-host. So if you want to share anything with us, some visuals or something, you can do that.
Oh, yes, I can do that. Let me share my screen, but first let me get my presentation. There it is. And starting it up.
Where are you based yourself? Are you in Delhi or in Mumbai or?
I'm in a place called Bangalore.
Oh, Bangalore. Okay.
Yes. Give me a second. Now let me.
The more technological center of India.
Absolutely.
That's why you have such good internet connection, I see.
Yeah, I have 100 Mbps connection. Of course, when it works. All right. So are you able to see my screen?
Yes, now? Very beautiful.
Wonderful. Thank you. So let me move ahead. So basically, the Ambu Pod is a sustainable, scalable, and a cost-effective solution for providing near-doorstep primary healthcare services to small and distant villages in India. We are not interested in going to villages where you already have a doctor or you have a nurse or something like that. We are not in competition. We are there to provide care where it is not available. So now moving ahead, as this is just for information that almost 70% of Indians live in villages. 600,000 villages. And like I said, there are just about 24,000, let's say 25,000 primary healthcare centers. But only, please note, 13% of them meet Indian public health standards. So it is pretty bad. And things like communicable diseases, lifestyle diseases, hypertension, diabetes, everything is there in the villages now, which is really affecting them. And I will not go through, India being the world capital for diabetes and so on and so forth, but it is very clear that we need to take quality-based healthcare literally to the doorstep of each villager. And we have to do it through the circle of care. So what is this, the circle of care? We can provide the circle of care. We'll talk about it more on the next page through our solution, which is called the Ambu Pod, which is a robust, affordable, scalable, and quickly implementable rural healthcare solution. Now, what is the circle of care? Essentially, we are saying that we need to give everything to the patient, like we do in the cities. It would be a circle of care where, like any care center or system we have in cities, the patient should have access. He should be able to get consultation done. He should get triage done, testing, drugs, advice, transfer to a hospital if required, follow up, everything, the circle of care. And this is the Ambu Pod solution. As you can see, it is a vehicle, a three-wheeler, which has been modified to be able to take a lying patient and two seated patients, or a doctor or a nurse who can provide care in the ambulance while the vehicle is in motion. ECG, uh, oxygen, suction, everything that you require is there. It can run on electricity or on diesel. We have different models. It has applications, telemedicine applications, medical and lab consumables. It has 51 tests, and you can give consultation by MBBS doctors and also referral to specialists for consultations. We also create jobs there because we pick up a man from the village, teach him how to run the system, train him, and thereby ensure that we are offering a job, and also we have a person who knows the local language and is able to converse with the doctor. So even if the doctor speaks in English, it does not matter, because that person will translate into the local language and look after the patient locally.
Yeah, but that's also one of the issues in India, right? You have more than 300 different local languages.
True. So that's the advantage of picking up a local person. We give him a job, we give him an ability to look after his village, and we also are able to use him as a translator. So the idea is to do multiple things with the same person. As you can see, our ambulance come clinic, the Ambu Pod, is fully equipped. It's got the time-tested Ambu bag. It's got oxygen. It's got suction. It's got various equipment. It's got a 12-lead ECG machine. It is just the size of a credit card, as you can see out here.
How about dental care?
Dental care, we have talked to dentists. You see, a lot of dental care is physical work, right? Plus, another thing is that out there, very little of it is advice. We have spoken to some dental surgeons. We are looking at if we can create a single chair dental clinic in the Ambu Pod, but we haven't yet got to it, because end of the day, everything costs money.
Of course.
And we need somebody to fund us for it. As you can see, we have a pulse ox meter. We have, all the equipment. Oh, sorry. Went forward. Yeah. We even have a fetal Doppler so that mother and child can be, monitored, glucometers, and a lot of other tests, additional tests as per your requirement. And as you can see, we have everything that is required. Our latest addition now, keeping in view the cost constraints, is to give a kit without the ambulance. So if a person has a scooter, he can just carry the kit with him, and he can still look after patients. So that's the additional change that we have added. Now, these are the tests that are available, 51, and we are adding on to it. You can use for multiple activities that are required. So,
okay. You do these tests locally, or you have to send them somewhere, I suppose?
Right there, point of care.
Oh, wow.
Everything, all strip tests and other equipment, like as you can see out here. And of course, for every test that we want to do, we will have to buy those kits. So those are the consumables that again have a cost. But a lot of these tests do not need anything. For example, eye tests.
Yeah.
You don't need anything. You just have everything on your computer, on your tablet, and you also have charts, physical charts, eye test, color testing, for example, astigmatism, cataract, physical testing is there. Using our camera, the doctor sees the eye and says, okay, this person seems to be having a cataract. Hearing tests, audiometry tests, again, on this thing. Lung peak flow tests are there. Non-invasive jaundice tests, and so on and so forth. We can keep adding as many as we want. It all depends on the need of the hour. Our software has been designed to be, we have our telemedicine practice guidelines, which came out in 2020. In fact, I'm one of the validated, trainers to train doctors on the standards of the telemedicine practice guideline in India. And it's an Android browser-based client, and the hub is the browser-based hub which works on the cloud. It can work on a local LAN also if required. And obviously, the hub is a browser-based system, so it works on Android, Windows, or Mac, and any kind of system. It has a built-in electronic medical record, focus on structured data capture. It has built-in security powered by Google. It can operate with healthcare IT applications via HL7 modules. It follows standards of ICD-10, SNOMED CT, LOINC. It can provide e-prescriptions as per the telemedicine practice guidelines of India. Touch and user-friendly, blah, 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 and so on and so forth.
Yeah.
Right. The main thing is the low learning curve. And we can do it. You can use it for many, many kinds of cases, whether it be OPD care, for ear, nose, and throat, chest diseases, routine medical exams, screening and treatment of women, and so on and so forth. And multiple deployment cases. I will not even, sort of take your time with that. And we have a kind of a proposal also how we can do it, covering a maximum of 24 villages if required in this kind of a standard format. So just zooming through it, we have given some kind of costs also. But to summarize, the Ambipot solution is an affordable solution to take quality-based healthcare to thousands of villages. Our idea is, can we hit at least 50,000 villages? And we are looking presently for funding for grants by which we could do a 100-village pilot. So we have qualitative and quantitative data. Because the idea is, once we are picking up a lot of validated data, structured data, which is put on the cloud. So this would be used for analytics, and we are hoping to use it for predictive analytics. So let's work together to provide healthcare with compassion.
Yes, shall we interact? Because I see this not only as an opportunity for India, but also for other places where there's a lot of rural activities. And a couple of weeks ago, we had a discussion here online with somebody from Morocco who is very worried about the development in Africa on childbirth, child death, and overpopulation, also because of very precarious circumstances in Africa, which is probably also the case over there. When the level of wellness rises, the amount of childbirth decreases, but the health is increasing. So child death and all these kind of things are kind of get different type of proportions. So if we really want to look at a broader perspective of health, I looked at your circle of health. This weekend, I was in Belgium, and we were talking with general practitioners who were looking at their healthcare activities in a country, a modern country like Belgium, where there's quite a density, obviously, of healthcare. That about 25 to 50% of the healthcare visits of people are not not directly related to medical needs. They're related to all kind of other needs, like emotional needs, spiritual needs, other kind of needs, not of whatever. And so there should be also a circle of care which connects to other circles of care and to develop a community type of spirit based on broader levels of health.
Absolutely, absolutely. I agree. In fact, the Ambu Pod has been made to take care of not just physical health, it's been made to take care of mental health.
Yes.
Spiritual, we can get it because it's video conferencing, right? It's very easy to do that. And we take care of even Ayurveda, our Hindu system, our Indian system of care, and even homeopathy if required.
Mm-hmm.
So that's how we can expand. There's no problem because it's a healthcare platform.
Yes.
And when we talk of healthcare, it's not just curative care. It is wellness.
Yes.
Excuse me. Can you give me a second?
Yeah, sure.
Somebody's been constantly calling me up. Dr. Lavanian, hello. I'm actually in an international call right now. Is it okay if I can call you back in a couple of things? I'm in an international Zoom call. Yeah, I'm so sorry. I'll just call you in an hour from now. Is that all right? Yeah, the 5G presentation. Right. Thank you so much. I'll call you back. Yeah, thank you so much. Bye bye.
Okay. Well,
I'm
it
so
is.
sorry.
No, no, don't worry about that.
See, we are working with the government actually. We are trying to now start 5G trials
Mhm.
for using healthcare through 5G networks. And the government is trying to start up with some trials where they want a healthcare scenario also, a healthcare demo. So
Mhm.
we are working with them. We have to give them presentation. That is
All
the
right.
government officer calling me up.
All
Sorry about
right.
that.
As I mentioned this weekend, I was talking with house doctors, and there were about 30 in the conference, and I was introducing Sustainocracy, which is the society based on health proactively, health preventively on health, but also developing health as a main mean of governance, also not only money driven and money dependent, but specifically based on health. But anyway, that is the type of reasoning why we are here together also. And we were introducing a, technique or a vision which is positive, called positive health, which helps people to also establish an understanding of what health is, which is much broader than just the absence of a disease. So it's very interesting to do an interaction here and also develop rural part, because we see here a tendency, and maybe with COVID, there is also, I've seen videos from India where there's a tendency of people from the cities moving back to rural areas because there is a better chance to have their feeding and do other kind of and have your basic needs fulfilled, but also to get out of the ghettos of the cities and those kind of things. Anyway, there's a lot of things happening, and your service there can be a very powerful device there. But I would like to others to also interact, maybe Heiner or Kupeme. What can you say about this? And also, as you do that, maybe you introduce yourself also to Dr. Lavanian. Who is the first? Heiner.
I'm Heiner in Berlin. I have very high, how do you say, regard for people in medicine, because the original medicine was helping the general system sciences, all our modern thinking coming together. And the eldest and father was Paul Weiss, who influenced Bertalanffy and so on. And so I'm a retired, very active scholar and activist and consultant and whatever. And I feel very much that your approach on multimodal and integrating science systems and representation and looking into the improvement of communication, maybe even with people in different languages, or they have just other cultures and whatever, is very much up to date as we see in the field of medicine. We looked with the Advisory Committee for Global Health Research, advising the DG of WHO in the 90s. So I'm just a geophysicist, but I always said I'm a geophysician. So I'm really in between. And I have very high regard of the Ranganathan Library in Bangalore. Not only what everybody knows about computing, and the computing hub of India is Bangalore, but how to put it into frames of references to really negotiate that. So I think your approach is very timely, especially not maybe for remote medicine. So I think remote operations is something different than finding out what is the status, who needs help, on which scales and with which urgencies. This is only a little first response. I find it very interesting. I would like to see it in written. I only could glance at your presentation, but I found it very interesting because I'm here working besides. So we are really torn apart in the world of Zoom nowadays. But I think it was a very interesting selection to have you here with us today. Over.
Thank you.
Yes, we're privileged. Thank you. Thank you, Heiner, for this comment. Ukpeme, you want to say something about this? I don't know if you're still there, Ukpeme. Ukpeme is our peace officer and ambassador, and she lives in the United States, but she's originally from Nigeria. And she's organizing a peace musical festival in Nigeria for peace in July next year. Were you taking the benefit now of discussing what peace really is?
Yeah, I'm in the middle of an international Zoom call. Can I call you back? I would ask 1 hour. Sorry, you don't mind. Yeah, I'll do that. Huh? Sorry. See you. Thanks. So sorry.
Don't worry. When you receive a call, maybe you can switch off your microphone, because then we can just talk and we don't disturb you.
No, I'm not disturbed. No, I can.
Right.
But I'm sorry that I'm disturbing you folks.
Don't worry. Don't worry. It's simply late night already in your place, so you are a very popular guy, even late hours. I don't know how that will affect your health in the long term.
It's not a problem. I try to balance.
You try to balance, which is one of the things of broader health and positive health, to try to find balance and belonging and all these kind of things. And one of the key elements that I find in India also very powerful is still your knowledge about plants and homeopathy. Those
Ayurveda.
Yeah, and that we have lost very much because of the influences of the pharmaceutical industries here. But in India, there's still a very powerful knowledge about this. I don't know if you feel, as a high-level medical specialist, obviously, to also take these kind of things into account.
No, absolutely. We are perfectly fine with getting a mix of both. For example, what do you call grandmother's remedies also, for example.
That's right, yes.
Problem here, don't take an antibiotic. Do one thing, go and mix ginger, go and mix a little bit of ginger with this and that, and so on and so forth. We do use these kind of things, and plus we have Ayurvedic doctors who we do refer people to. I'll give you an example, like jaundice cases. I've actually cured them by giving them herbs, because I know that from allopathy, I can only do a certain amount of stuff and the body has to have rest. But with these Ayurvedic, herbs, I've actually crushed them by myself, in a pestle and mortar, and given it to my patients, and they have improved in 3-4 days. So these things do work. We have to have a fine balance. That's the main thing.
Absolutely, yeah. I agree with that. Balance is not a status quo. It's hard work, and developing control mechanisms, also letting go, and from awareness, developing totally new kind of things. And that is the type of thing that we're working here all together. Anyway, I will stop the recording, because then I can share this also with other people as a specific unit of our discussion.